All right. It is my pleasure to introduce our guest speaker today, Paula Konomos. She's presenting on using the minimum data set to tell a story. Paula's been a registered nurse since 2012 and has worked with MDSs since 2014. She specializes in Medicaid reimbursement and systems and quality Medicaid reimbursement systems and quality measures related to the Resident Assessment Instrument, or the RAI. Paula is currently supporting more than 50 skilled nursing facilities across 8 states to improve quality outcomes and accuracy in Medicaid reimbursements. And in her free time, she plays the cello, piano, and Gaelic sports. So Paula, the floor is yours. Thank you.
Thank you, Jill. Hi, everyone. Thanks for joining me today. I was hoping to kind of share a story with you. You know, a lot of us think of the MDS as, I think, initially a document for payment. I think a lot of us should recognize that it is a document that's important for data collection to help drive a care plan. But I think it might kind of help if we also thought of the MDS as a story or a collection of stories, rather chronicles in long-term care. Perhaps a skilled nursing facility saga where we get stories from the MDS RAI. I'd like to start with a quote from Oprah Winfrey, right? Where everyone has a story, and there's something to be learned from every experience. I say this because I think it's really important to remember that each and every MDS we do counts, right? Regardless of payer. And every single person coming to us under our care has a story to tell. They have a story that brought them to us, and they'll be telling a story while they're with us and after they leave. So again, every single story here counts. And while most stories start with once upon a time, the stories we tell here will be told more than once upon several obras. When we think about, I'd like to back this up here and think about how, how our stories are collected, right? First, we collect a lot of data. And in this day and age of big data and big tech, our ability to collect and interpret information has increased exponentially every year, I'd say every day even. And in some sectors of business, this data that's being collected can be more valuable than oil, right? And in our industry, in the SNF segment of healthcare, CMS has created a database language that allows us to collect this data on our clinical processes and outcomes, right? Which are then kind of published out to the world, right? They're collected, reported, analyzed, and published out there for the whole CMS world to see. And the telling of and the collection of this data has become extremely significant, an extremely significant factor of success for many SNFs in the country, right? So as leaders in your building, do you know how your data is being collected, interpreted, analyzed, reported, and published? Or in other words, do you know how your story is being told? Okay. Sorry. So as we move to tell stories, right, we a story is really a collection of chapters that are rolled into novels, which then can be like a series or a saga. The MDS itself represents a chapter in a resident's story, right? It's a segment of somebody's stay within a SNF, right? And it kind of records a resident's encounters and events, their outcomes and their presentation. Okay, and if a resident stays with us for a while, then they have a collection of these chapters, at least a minimum every quarter, right? And the collections of these accounts and stories is really a reflection of the resident's overall experience within a SNF. Their story that's being told while they're with us. And a collection of these stories chronicle that center's saga or their impact and their reputation within the community on local, state, and national levels, right? So you're leaving a legacy here when you have this collection of individual stories that are being told within your center. So it's just, right. So, right, as we think about this again, you have you move from chapter, which is the MDS, to novel, right, which is an individual's experience within the SNF, to a saga, a collection of multiple individuals, right, which is really all about your SNF reputation and your legacy. I'll use kind of like an example because you're telling a story here on at least two different levels. And I use this graphic here with the rocket and this planet, say like if the story it takes to get somebody to the moon, right? You have the story of the individual person and what it took for them to be the person to get to the moon. And then you have the story of the team or all of humanity that got them there, right? And that legacy that we're leaving behind for that accomplishment. So I'd like to introduce you to the contributors of the story and their roles. Okay, the story is nothing without content, and you need a content creator. And I liken this to the role of the DNS, right? They're driving the clinical stories that are happening within each center, right? What does the resident need? How successful are they going to be? Will they be able to reach their goals? Right, they're driving the clinical story for each and every individual. I look at the executive director as kind of the operator of the business of telling stories. They know how each story will affect the business, and they provide the platform, the technology, right, and the means to have efficient systems to tell these stories accurately and timely. The MDS coordinator comes out as kind of an author or historian. I would also like to say, I guess in this case, a translator or if we're writing this is all nonfiction, so I would say ghostwriter, right, where they're right there with the person who's creating the story, or DNS. They're right there alongside them, seeing the same story, but they bring with them this skill of writing a story, right? And the MDS coordinator knows how to write in this alphanumeric code that CMS has. It says, I know how to write this pressure ulcer into the CMS language. Okay, and so the MDS coordinator is there to help reflect that story accurately to the CMS world. And they help the DNS and the IDT understand how to translate that story that they're trying to tell to the world of CMS. Okay, and then the IDT, the interdisciplinary team, acts as an editor as a whole, right? They're there to approve the story. Yes, we all agree that this is what's happening with the resident, and we agree that this is what should be published to the CMS world. And then when it gets to CMS, right, CMS acts as kind of a publisher and a critic at the same time. So they have not only established how the language that we're telling the story in, right, but they're also telling that story to everybody else that speaks that language. And then on top of that, they're providing, right, so they're publishing this out to everybody. And then on top of that, they give you rates and ratings in terms of 5-star ratings and payments, right? So they act as critics and sponsors, all rolled into one role. So these are the contributors to the writing and publishing of the MDS story. So how can we kind of decode how this works? I'd like you to take a look through the RAI looking glass with me, if you will. Let me see if I can, oops, this isn't following. Through the RAI looking glass, we'll go ahead and try to decode a story. Okay, so if we have a lens, right, this RAI lens that can be seen through the MDS, right, which requires the IDT to kind of contribute to it. This lens here is reading this clinical document. You can see this kind of, these wiggly lines in the background represent a clinical document. And this lens here, right, which is being used by the IDT, is being read so that the team can coordinate, project, and validate the story that's being published, which will go into how your SNF, your center's success story will go, right? So the IDT is reading the chart through the lens of the RAI in order to publish accurate accounts of clinical processes and outcomes. Oh, and I'd like to mention too, that, the IDT here itself is managing not just one story at a time. We're managing many individual stories at once. And doing this requires, right, efficient processes and lightning fast communication, because the teams all got to see the same thing together. And this lens becomes less effective, right, without, if any one of these components is missing. How can we accurately tell the story of a resident, the success story of a particular resident, if we don't have their discharge goals that we created with, if we don't know their nutritional goals from nutrition services, or how do we know where they're going next without bringing social service on board, or how do we know that whether or not they're likely to participate because of certain activities that are available to them, and so on. Okay, this whole process kind of falls apart if we don't have the whole picture from the whole IDT. So most teams I've seen have some sort of system or process that addresses addresses these 4 areas, and I liken them to, writing a story from beginning to end. Many teams have an admissions process, a clinical meeting or process of some sort, right? Some point where they review PPS and perhaps a monthly triple check or validation of billable items. So the admission process here, right, we usually starts with a referral with, a resident's going to need some care, and the team will kind of have an idea about what kinds of services this person may need, the course of care, the potential course of the care that they have while they're here, what kind of goals they might need to achieve when they get in order to have a successful discharge, right? And we can kind of forecast what kind of outcomes there'll be. In some cases, if you're savvy enough, you can predict roughly which case mix groups, therefore your PDPM rates, whether or not the admission will affect your long or short term quality measures, and so on. And then when you have your clinical meetings, right, we're kind of reviewing the goings on of the people that are in our care. So once we have the admission coming in, we can review that baseline plan of care and develop a more individualized care plan to properly address a resident's goals for discharge, right? So we have the first draft of our story for how they're going to successfully discharge home or stay with us, depending on what their goals are. So, right, we have more specific details in this first draft of our story to allow more specific projections of groupings. And then when we meet for, say, PPS stuff, these are kind of like revisions or even follow-up clinical meetings too, revisions of our drafts. Are we modifying our care plan? Are we adjusting our ARDs? And are we, revising and validating our outcomes? Then when it comes to triple check, the IGT comes again together to validate that everything that we thought we were going to bill for, we're actually going to bill for. So we go through those UBs and we transmit our MDSs and we say, here you go, CMS, please publish to the world. That's our final draft of our story. Okay, so these are your systems that can support the development of your story and should be kind of checkpoints to make for the team to make sure that the story is going as expected. CMS and certain bodies can also provide tools and toolkits and reports that provide feedback on how your story is going, right? We have CASPA reports that give you feedback on the state of your quality measures in certain areas. You have manuals and user guides that help you understand how certain metrics are measured or how rates and ratings come about, right? Or the intentions of the RAI and why we do what we do. There are certain toolkits that are available out there from various companies and systems that allow your team to help coordinate, project, and validate those outcomes. The question is, is your team using tools available to them, right? And every team's going to kind of use tools a little bit differently, depending on strengths and weaknesses within your team. The question is, do you know how to use the tools available to you and where do they fit best? A lot of times teams will say, for instance, discuss pressure ulcers during a clinical meeting, but then do we talk about how and when they may affect, say, a PDPM grouping or quality measure or a case mix group? Are you guys implementing that? While we recognize that they have these impacts, are we ensuring that we have tools that allow us to track this? Okay, because when it comes to conducting an MDS, it's the one and only time where a team will look at a resident from head to toe, right? Do a full-on head-to-toe assessment and do a full front-to-back chart review. So it's the one opportunity for an interdisciplinary team to thoroughly narrate what's going on before the story is being published, right? And if the team can do this beforehand, then you have more. If the team can do this before it's published, then they have more of a hand in driving that narrative, right? They can choose when this ARD is going to happen and choose to reflect the most accurate story for this resident. I usually see a huge opportunity when a lot of times a team's solution for quickly improving, say, their quality measures is to look at their CASPA reports and validate for miscodings, right? At this point, you're already a month behind looking and driving your story, right? So if we can kind of identify those potential triggers and perhaps missed instead of going back and looking for miscodings, right, when you're looking ahead of time, you could probably see that if we had talked about this particular MDS a week before, we could have switched an ARD, or we could have provided more thorough documentation to reflect that story a little bit better. So once a team has already ideally proactively set that story and has published the most accurate one possible, right? Then we get reviews, we get rates and ratings from our critic reviews and sponsors in the form of 5-star ratings, PDPM, quality incentives, and case mix, depending on your state. So in your Care Compare 5-star rating system, right, there's 3 components, and each one of these 3 components is affected by the MDS, i.e., right, they're all still affected by that story. This is all how the story affects how you get your 5-star rating. In survey, a lot of times your sample size or who's in your sample can be determined by your Casper reports, right, which is all developed from MDS data. Also, the MDS itself is scrutinized during a survey. And then when it comes to quality measures, the data used to measure each of these is directly from the MDS and nothing else. And then when it comes to staffing, the acuity that's used, the acuity that's measured to determine your staffing rating is also affected by the MDS. That's all. It's a different kind of case mix system here to determine this domain. Okay. And when the story gets told, right, in addition to those star ratings you get from Care Compare, there's several different payment programs that give you your rates. Everybody in the country is participating in whatever the PPS system currently is. Right now it's PDPM, right? And this is how everybody gets their Med-A payments. Then when you have Medicaid related payments by state, usually they're related to things like case mix or some sort of MDS add-on or quality incentives. Looks like Wyoming, for instance, participates not just in PDPM, but they also are a case mix state, right? Montana has a quality measure program or quality incentive program based on their star ratings, in addition to their participation with PDPM. So teams that have that can tell the most accurate stories, and the key word here is accurate, right? That the stories that reveal the highest quality of care are rewarded with stars and funds. So, right, and I say accurate because if you are, let's say you're giving really, let's just say two-star care. Okay, there's no amount of MDS coordination that's going to reflect a 5-star rating for your system, right? At the end of the day, you've got to address why you're giving 2-star care. And the reverse is true. If you're giving 5-star care, it takes a good amount of MDS coordination to accurately reflect that 5-star care so that you accurately get your star ratings and you accurately get paid. Right, and if you are giving 2-star care, reflecting your story accurately helps you find where your opportunities are and where your strengths are. So how are you going to drive the story, right? What does that entail? Do you know how you got here, and do you know where your story is going? And the most basic kind of elements of driving a story have everything to do with being a bit more on the proactive side of things, right? Can you project, revise, and validate your outcomes? So, right, A lot of times there's a lot of effort spent mostly in this projection phase, if at all, right, to kind of see what could happen with a resident while they're here, or are we making sure that there are no triggers, say, for our QMs. But then what often is missing a lot of times is this process of validating. Are you inspecting what you're expecting, right? What are one thing that's great to ask, is what are the outcomes of the assessments that your MDS coordinator finished yesterday? And do those final outcomes match your projected outcomes? In other words, do my socks match? If I'm going to get dressed for the day and I know I'm going to look a certain way, right? Do I make sure, and I want my socks to match before I walk out the door? If I put on my left sock, right, and I expect my right sock to match, can I make sure that they match before I send it out, before I walk out the door, right? Or before I publish my story? For those of you who are more mathematically inclined, does the X projected match equal my X actual? If I said I was going to get this certain HIPS code on an MDS, did it actually come out that way when I actually did it? Right? And the purpose of doing this is just to make sure that maybe, fingers weren't flying fast, or that a resident participated as expected, or that we documented what we thought we were going to document in order to produce a certain outcome. Okay, and I think one of the most important things in these practice is to make sure that small steps is to recognize that small steps have large impacts, right? Especially in when it comes to longer term outcomes like quality measures, or possibly case mix, depending on your state, where you don't see the impacts of your efforts until about 1 month, 3 months, a quarter, right, 6 months, or a year later. So it's really important for you to not only anticipate your outcomes and validate them, but to do it every single day, right? If you can do this every single day, it's most likely that you've maximized your revenue and that you've gotten as close to 5-star care as you can, or that you're on your way because you've recognized your opportunities, right? And I say every day, again, because every single story counts, and will impact your revenue and your star ratings, right? The IDT has to commit the same level of rigor to all stories being told, because every story makes an impact. So we can't just focus on looking at the HIPS codes for our Med-A patients, right? Because that will really only affect your Medicare revenue. But are you also seeing how those could potentially impact your quality measures and your case mix revenue, right? Has your IDT developed the skill where they could say, well, we can afford to take the hit on our pressure ulcers because we'll still have 5 stars, and we should take this ARD for the case mix this quarter, right? If your team can work on having that kind of level of discussion, you really have a huge opportunity to drive the outcome of every single MDS that's being done in your building. Right, and if you're able to do this also, then we should really never have to review a CASPER report for accuracy, unless you really are just looking for maybe fingers were flying too fast, right? But it's probably less likely that if you're doing this every single day, you're probably going to hear that the MDS was miscoded less often, right? Because you will all know what we're supposed to expect. Right. So when you think about, right, like the MDS as writing a story within your center or a collection of stories within your center, you recognize that we're doing a lot more than just collecting data. And we're doing a lot more than just collecting data for payments, right? This is data to drive a care plan that's going to affect how successful somebody will be while they're under our care, right? And if we do this many times for many individuals, we'll be chronicling collective histories and leaving legacies within our communities. So the question is, how will you be a part of that story? Right? Because all we are, at least in the eyes of CMS, is the legacy that we can leave behind. The end. Any questions, comments, concerns?
Jill, I've been chirping away, and I just caught that, Dana, thanks. And what I said was so profound. I just was thanking you, Paula. And I just also wanted to acknowledge that I think that we're all becoming increasingly aware that what's being reported on our MDS is also being reported publicly, and it's impacting us in ways that it never before used to. I know in the market where I live, the hospital case managers provide an iPad, if you will, to prospective residents as they're making selections about which nursing center they're going to go to for rehab or for long-term care. And they're relying and they're looking in some cases only at the data that's been generated from the MDS as it's being populated in the five-star rating system. And so it's just really critical that we felt like this feels very foundational, this presentation today, and that was intentional on our part because there's a lot of new MDS coordinators. This pandemic has shuffled things around and unsettled, folks in their current roles and made a lot of shifting. And so we recognize that this was a pretty basic webinar, but it was intended to be that way just so we can start to then build on the rest of the MDS story, if you will, or the process. And so it was a nice analogy, Paula. I had to do a double take on my shoes. I usually wear the same color socks, but sometimes I get two different shoes on. I don't. It's happened before. So does anybody have any questions for Paula? Maybe even not related specifically to this particular presentation, but she really is an expert on a lot of these processes. So now's a great chance to catch her.
Yeah, so I'm actually reading Barb Bigelow. The triple check process there for LTCs who bill Medicare SNF. The triple check process is exceedingly important, and it should include therapies, coders, and nurse leaders in addition to MDS coordinator. And yes, wholeheartedly agree with that. Triple check is an interdisciplinary process, and which I think I'd like to piggyback on top of that too. I think the point I was trying to make for all of this is that the MDS process, or that all of this is really very interdisciplinary, right? I really want to hit home the role of the MDS coordinator there is to see what the IDT or what the DNS and the clinical team is seeing, but to help, but to also be that RAI expert who can help the team drive and translate, right, how your processes are being told to CMS, and having the whole IDT part of triple check to validate that all of that is coming out is incredibly important and should not be ignored just because somebody says that they don't understand a code.
Paula, what would be the role of the administrator in all of this, would you say?
So I think on the slide that I had there, the administrator is there to help provide that platform. Make sure, right? A lot of times you need a leader to keep the team on track, right? And to provide to provide the tools necessary, the space, the technology necessary, right? But who puts the business together so that the team can really kind of drive a lot of this, right? The DNF, like I said, would be the content creator. They're driving how successful each person's story is going to be while they're with us, right? Which is a story of their own success itself. Okay, and the MDS coordinator, because they're also a nurse, right, can assess and see a lot of the same things that a DNS does. But there's two different skills there where you can see like the same situation, right? But you bring two different things to the table. So your DNS is going to help that person succeed while they're here, and that MDS person is going to be right alongside that DNS and say, great, this is how successful that story was, and this is what it's going to look like to CMS. You know, or this is how not successful it was. Maybe we should improve this, and this is how we'll capture that success later.
Great, thank you. So if we have any newer MDS coordinators on this call, Paula, what would be your advice for them? If you were to kind of walk out what their priorities are for the first like 2 or 3 months on the job, what might that look like?
So as a brand new MDS coordinator, right? It would behoove you and your team to really get to know I guess, why you're doing what you're doing, right? A lot of times we get trained by word of mouth. And if you start asking why you're doing what you're doing, you'll start to get to know the regulations, right? I think that I think one of the best advice I was given when I was a burgeoning MDS coordinator was I was told that my UR nurse, she read a chapter of the MDS or a section of it, RAI, every single night. I didn't do it. I didn't read it every single night, but I read it quite a bit. Okay. And I think becoming familiar with that piece first really helps you understand the intent and the role of the assessment itself, so that you can be the person that your team can help say, hey, you know, if I put this ARD here, you can be there. I think it's really important also to develop, in addition to just that basic skill knowledge, it's important to develop that relationship with your director of nursing, right? I think that those two roles tend to butt heads quite a bit because you're essentially an internal quality assurance person where you're going to have to bring some bad news that says, hey, you're not documenting good enough for us to code this, right? Or you are and you aren't, but you also have to say, well, here's how I can help if you guys are having this kind of issue, right? But it's also kind of important to create those boundaries because you have to be able to do your MDSs timely, but still be able to kind of support the success of your team. Okay, so working really close with developing that relationship where you're seeing what your DNS is seeing and helping them understand the MDS, right? If you're new, at some point you'll become an expert and you'll help your team understand why they're doing what they're doing, because you'll help the IDT understand how their roles impact the MDS, right? So that coordination, you'll be a persistent, annoying person present among everybody because you'll have to know a little bit about everybody to get them to contribute appropriately to the MDS.
That's true. Yeah, that's very helpful. I think. Are there any newer MDS nurses or coordinators on this call that have other questions or follow-up comments about what Paula just mentioned? While folks are thinking about that, Jesse Kinsey notes in chat, just asking the question, why?
Yes. Yeah, you know, I think that point in particular, like why do I have to set an MDS here? Why does the team ask about dates? Why is it, you know, Do I have to make a cert for a Med Advantage? Why do I have to make a cert for a Med Advantage patient? A lot of times, if you ask why, you'll actually save yourself a lot of work, realizing that people do things from 20 years ago that are no longer necessary. Right?
That's a good point. Or we've always done it this way, or somebody trained somebody else to do it and never got questioned, and they carried on with that unnecessary or poor practice.
Right. I mean, you may open up some cans of worms, but at the end of the day, you'll have a better understanding of how to work a bit smarter to get the same results or even better ones, right? Because you really want to be super efficient, especially as your census grows, right? And you have to handle more and more assessments.
I heard you mention in your previous comment about sometimes the difficulty or the strain maybe between an MDS coordinator and a director of nursing. And you used the example of documentation. Do you have any little nuggets regarding documentation, Paula, that you found? I mean, that's kind of the key, right? Because it has to be documented in order to then articulate that on the MDS. Do you have any words of wisdom there?
Be delicate, right? When it comes, I mean, I think when I was very new and I was trying to work with RCMs and a DNS, I'd say, guys, can you help me? Like, this documentation sucks. You know, why aren't you doing any better? I could have been a lot nicer about it, right? But then I also started to learn when I started to travel around to do MDSs, it became actually pretty handy if I went ahead and wrote some things myself that I knew were going to be hard to find, right? Because you have to recognize that nurses we don't learn MDS stuff in nursing school. So nurses on the floor are not going to document perfectly what you're looking for, right? And if you're going to have to go and document for somebody anyway, I would recommend having an olive branch, because you are a nurse, there's some things you can do to kind of set an example and show the team what it is you need, so that hopefully you can kind of work with them to say, you know, every time we are going to document shortness of breath, can somebody tell me what position the resident's in? And if I do it, maybe somebody else will do it, because, you know, use copycat charting to your advantage. You know, to that extent, in terms of educating. I hope that hit that. Olivia here says, besides the RAI, are there any other resources or sites you could recommend for MDS questions and assessments? And Marilyn below says, a PACN association is great. Yes, highly recommended. I really also recommend reading those forums that if you're an PACN member, they have those forums where people ask great questions and there's a ton of responses. I've asked several on there myself and have used it. The CMS website, outside of the RAI manual, the CMS website has the quality measure user manual and actually all manuals that are relegated to that. If you belong to a certain state, I actually have, you know, my state's RAI coordinator in my phone so that I know I can call them for things that are related to this. If I need a website to go to, you go to your state's website for those. If you don't have one, reach out to your RAI coordinator for that. And don't hesitate to ask them a lot of questions, especially if you're in a state where case mix accuracy is a thing. You might want to know how your state actually reviews those. And then Barbara also said, I have also found and endorsed that MDS coordinators reach and teach all the caregivers in the home to achieve better documentation. Correct. Yes. Again, as the expert, you'll be there to not only teach. When I say IDT members, I mean not just your department heads, right, but everybody in the SNF. Back in the paper days, I used to try to teach, you know, those ADL pieces. I would have Post-its next to the CNAs, or I'd go in and help provide the care. And because, you know, it's often hard to find a second person, and then it'd be a win-win. If I help you with this, I'm going to quiz you on how you're going to document this, right? Just to reinforce education that's provided. Alaska's HFLC does not have an RAI expert and refers us back to CMS. I did not know that. Well, I suppose I wonder if Alaska's, I'm sorry, HFLC is, can somebody help me with that acronym?
It's Health Facilities Licensing and Certification.
Oh, okay.
Yeah.
And they refer you back to, so they just use base regulation. Is that correct? I suppose at that point, sounds like Alaska has a vacancy open if somebody would like to take that role.
Maybe they had a vacancy they didn't even know they had, right? Or a need they didn't know they had.
Right. Yeah, I mean, I'm familiar with states not having additional state mandated elements. I think I'm only familiar with maybe California having that. But yes, a state with a small staff can be a bit hard. I'm wondering then, for the purposes of the support here, can people default to reaching out to Mountain Pacific and for their needs for right now?
Yes, Paul, I'm glad you mentioned that, of course. You know, we're the consultative hub for all things nursing home related. So by all means, reach out to us, and our job is to connect you to the resources. So that's a good point, Paula. Thank you for making that. We'll figure it out. We'll find the right connection for you for sure. I have another question, Paula, if it's okay. We didn't really plan this, but I hope you're rolling with me just fine. So thank you for that. So I have another question. It has to do with a lot of facilities have a morning meeting or like a stand-up time when the whole team is gathered to get the day started off right. Do you recommend that the MDS coordinator be a part of that team meeting first thing in the morning, and if so, why is that, or what would be the questions they would ask, or what would be their contribution?
So 100%, I think the MDS coordinator should be a part of all of those meetings. And it's really, again, to keep a pulse on what's happening with that clinical story, right? How do you know what's happening unless you hear what the team is talking about, right? How do you know what the plan is? Because you can't really exactly see the plan if you're just reading a chart, right? Right. Especially if we're trying to drive the story ahead of time and be a bit more proactive instead of reactive in how we coordinate with people. And like I said before, if you're if you're an MDS coordinator, right, trying to develop that relationship with your MDS, with your DNS, it would behoove you to probably be a part of that clinical meeting so you can see what the DNS is seeing, so you can make an appropriate translation, right? It's always surprising to me when I see that a DNS and an MDS don't know who has a pressure ulcer in their building, right? Or they have different ideas about who has it or what, because what's going to happen is, like, what that means is that while the DNS may be, say, healing out a ton of pressure ulcers, if MDS has no idea until a month later, whenever an MDS is due or whatever, you kind of lose an opportunity to, I guess, take credit where it's due as soon as possible, right? It's not like in short, I would say, as an MDS coordinator, you need to be involved as an IDT member with what's happening, right? Not necessarily because you're gonna be pulled to the floor or have to provide the care for anybody, but because as part of the data collector who's helping drive a care plan and making a story translate, you need to be just as on the pulse as any other IDT member. You can't be working 7 to 14 days behind what's currently happening in your building if you're going to help the team coordinate what's happening. Okay, and a lot of times, again, you can still be that feedback loop, but you can also be a more proactive, here team, I can clear that pressure ulcer from your quality measures, and we can also get a great case mix out of this at the same time, right? Right, because you healed that pressure ulcer yesterday. I don't have to wait a month from now to find that out, because that person's ARD isn't until a month from now. Okay. be just white. We do stand-up meetings in the AM, and it does allow for more care coordination with the departments in addition to other meetings. Great. Yes, having your stand-up, right? It's not only important just for MDS to be there, but if you have a morning meeting, it's really for your whole team. I think if any team member is missing from your morning meeting, something's wrong, right? Especially when you have in your smaller buildings where everybody's kind of got to wear multiple hats. If anybody's not going to that morning meeting, you're probably miscommunicating something. And to that too, I would say, you know, as an MDS, if you're new, if you're this new MDS coordinator again, don't be shy. Like, speak up and say, hey, this is missing, this is what I need, or insert yourself in places where you know, like, there could be a point of planning for things that could affect your MDS, right?
Great comments. I'll just share, I had a couple of responses while you were speaking early on, Paula. I just put in the chat box any future ideas for MDS work. We acknowledge that this is, we hope to be the first of a series of MDSs or offerings for MDS, all things related. And we had a couple of responses, and one was to maybe some ideas on how to use and interpret CASPER reports and quality measures. And then, yeah, so that seems like an important topic to consider for future offerings. And then also just this person acknowledged that they do have new people in this role and just how to properly fill out the MDS. There's still, you know, some interpretation opportunities or barriers maybe in that process. And so those were two of the ideas that I received during this webinar. So does anybody else have any closing questions or comments that you'd like to ask before we close out our call today? We know everybody's busy and it's hard to make time to educate yourself, but it's just so important that you're armed with the skill sets that you need. And the MDS role is oftentimes not as noted or acknowledged as we think it should be, because it's really, really a big deal. Having the skill sets that you need to succeed is important. I'd like to just point out that there is an evaluation link in the chat that helps us to understand what we can do better when we continue with presentations. Oh, here it is again, Mary. Thank you for putting that back in. So if you would take a minute and fill that out, we look at all of those responses, and it's helpful for us too. We're a quality improvement organization, so we have to also work on improving our efforts. There's another comment in here. Let's see. Could there be additional training in the mood and behavior areas, especially with dementia residents? Okay, I'll make sure I take a note of that too. Thank you for that. All right, last call for any other comments before we let her go. Paula, we kind of took advantage of you since we had some extra time at the end to pick your brain. So thanks for rolling with us on that. We appreciate your knowledge base and your being flexible with us. Thank you so much.
Sure, anytime. Happy to share. And yes, thank you all for joining me today.
All right, well, everybody take care, be well, have a nice long weekend. I hope you get time off. I hope you don't have to work the night shift for call-ins. That's the other problem with the MDS position I've noticed in my years of working as a provider. We have to guard those positions, don't we? Take good care of ourselves too. All right, everybody, take care. Thank you so much. And until we see you again.
Thank you.
Thank you.
Bye now.
Bye-bye.
Bye.